Hello everybody, my name's Alana. I'm currently one of the clinical educators in practice development, but prior to that I used to work in A&E for a couple of years. I know that A&E can be a little bit of a daunting place for some people. There's lots going on, lots of different areas. So I've made this session for a couple of reasons really. So let's just have a look at the objectives. So first objective, we're going to have a look at, I'm going to talk through all of the different areas of A&E at how they stand at the moment, so we can sort of understand what goes on in each place and what happens to the patients. We're going to have a quick look at the role of the nurse in A&E as well as the student nurse. Then I've picked out 5 different sort of the most common presentations in A&E to give you a bit of a flavour. We're going to look at the different sort of questions you might ask if you're assessing them, red flags to look out for, and then talk a little bit about the treatment options for those presentations. Overall, I hope this session's going to make you feel a little bit more comfortable if you happen to have a placement in A&E, or if you want to go and do some work there either before you qualify or after. And if you work on the wards or any other areas, you are likely to have patients that have come through A&E, so it's quite important that you can sort of understand where they've been on their patient journey in the hospital and you can talk to them about it. So a little bit about the Norfolk and Norwich A&E, just a little introduction. The area we cover is, got a population of probably well over this now, 600,000 people we could potentially have through the doors. We treat around about 108,000 patients a year, probably again going up every year. We've got roughly 250 nurses and healthcare assistants that work in the department. That doesn't include then the doctors, the cleaners, housekeepers, the receptionists, hundreds of members of staff. We were the first county to have its own OPED, which is Older Persons Emergency Department. This has actually been paused due to COVID at the minute, but I will talk about that more later on. So I don't know how many of you know, but during the whole COVID lockdown situation, A&E here was split into 2 areas, a green and a yellow. Yellow being for suspected or confirmed COVID patients, and green for basically everybody else. This is now, from a couple of weeks ago, beginning of June, gone back to normal with just one A&E, all green, same department as it used to be. Patients are only being tested for COVID if they are definitely going to be admitted into the hospital and they've got really clear symptoms, so definitely a really dry, consistent cough or temperature, and those things can't be explained by anything else. If they do come into the department and they have these symptoms and there is a possible COVID, we're using the standard sort of respiratory isolation precautions, the same as the flu at the moment. So they'll go into hopefully a side room, but if not, then a bay with curtains, and that would be deep cleaned once they've left. All staff are wearing, across the hospital, surgical masks, gloves, aprons for all the patients still, so that hasn't changed. This is all again liable to change every week, every month, depending on the situation in the country. If we have another spike, or we've got, there's hundreds of different factors, but this is where we are as of end of June. So now we're going to just talk through the different areas of A&E or ED, emergency department. So this is going to be a little bit confusing without actually walking you through, so try to just take in what you can, and again, if you do go and work there or go on a placement, you'll get lots of tours and you'll very quickly learn where all the different areas are. So streaming is the first area. So this is really, if you were a walk-in patient, this is the front door where you would enter the building. So as I said, for walk-in patients, quite a senior nurse who's had some training in this will greet the patients at the door and ask them really basically, what's brought you in today? And that answer should be really short and sweet. So chest pain, tummy pain, fallen over and twisted my ankle, or I've got some bleeding of some kind. They'll get a little bit of tiny little piece of paper, have their name on it and why they've come in. And then that streaming nurse will direct them to the appropriate area of the department, which I will talk you through. So that could be minors, majors, which is the main department, CHED, which is children's areas, resus, or the GP pods. So the idea of this is it's a really quick decision that can be changed, and it often does get changed once patients have gone through a fuller assessment. And the idea is to share out the patients between all the areas so that it's not sort of gridlocked in one area, and patients will then get seen a lot faster. It does work really well. Yeah, and that's it really. So after that streaming, then they will go and see the triage nurse, which many of you might have heard of before. So there's a couple of different areas in our A&E for triage. One of them will be in the main department or majors. One is in minors, there's one in CHED, and there will be roughly a triage nurse in resus as well. So wherever that streaming nurse decides to send each patient, they will then see the most appropriate triage nurse. And all the patients are seen in time order of their arrival, and then they'll get called in one by one, sit down with a nurse, and she will basically take more of a history. So what's brought you in today? So she'll have the note in front of her. She'll do something called a Manchester triage, which is a number category to assign people like a severity. So do they need to be seen immediately, or can they wait? And this was often where you see people waiting for quite long periods of time. But we do always say, if you've been seen first, that means you are the most poorly. This nurse will have to do an initial set of observations, a full set. They might be able to prescribe and give some analgesia. A lot of triage nurses can prescribe under PGD, paracetamol, ibuprofen, or codigamol, or they might have to get a doctor to prescribe something else. These nurses can also book some x-rays after a really quick assessment. If someone's come in with chest pain, this is when an urgent ECG will be done, just to rule out any heart attacks. And then that nurse will direct the patient to, again, the most appropriate area. So it might be the area that they're in. So if they're in majors, they might say, yep, stay here with us. We'll get you seen by a doctor as soon as we can. Or they might say, actually, I think you're more appropriate to go and be seen in the minors area from all the information that you've told me. So they'll get sent back round to minors. Or they might realise actually that their ECG isn't looking too good, so they might have to go quickly send them around to resus. Just depends on that assessment. All of this has to ideally be done within 15 minutes of that patient arriving, and that is incredibly difficult when we've got queues out the door, and people do like to go into their history quite a lot. It takes the nurse, that's quite a lot of things for the nurse to do. They do have a healthcare assistant to help most of the time, but they've got to document it all on the computer, make sure everything's fine. They might have to go and ask for second opinions or referrals, so it is more likely that it's going to take you longer than 15 minutes, but that is the aim. And then at this triage stage, this is where the 4-hour clock starts. If you haven't heard of the 4-hour target in A&E, I do suggest you give it a little bit of a Google, a bit of a read. It's quite a hot topic at the moment, should it be continued or should it be stopped? Because basically it means you've got 4 hours to see, treat and either admit or discharge each patient. And the target is to have this done for 95% of patients or more. And this is one of those targets that is very often missed because we've got lots of queues, lots of patients, and each one is equally as complicated as the last. So there's lots of arguments whether this is actually beneficial or not. If a patient does breach that 4-hour target, then the A&E department and the trust will get a fine for that patient. And it does, it then does reflect poorly on the performance of that emergency department, whether that be right or wrong. I leave that up to you. So triage will then send that patient back out into the waiting room to wait for the next step or the next member of staff to see, which would usually be a doctor or a nurse prescriber, somebody with a bit more of an advanced skill. So ambulatory majors. So this is in what was the old RATS module, which is, if anyone's ever been there, funny little cubicles that have been put outside in the ambulance bay. And this is really recently, I think about the last 2 weeks, beginning of June, just moved out there. So this is mostly for those patients who have walked in. So they've come into the front door, been seen by the streaming nurse, into the triage nurse, and said, yep, you can stay here with us in the majors department. It might also be some people that have come through RATS, which we talk about in a moment, that are able to actually sit out in a chair, which is called fit to sit. Again, these patients are seen in time order or priority order. So that triage nurse might have thought, actually, you don't need to be in resus, but you do look quite poorly, or I'm a bit concerned about this, that, or the other. I think you need to be seen sooner, and that might just be that their News 2 score is particularly high, or there might be a gut feeling, or it might be something that they've just noticed about that patient. So each patient will get seen by a nurse, and the nurse's role is again to do a fuller assessment. So this is where they're going to take more of a past medical history, and maybe get timings of what's happened. So chest pain, for example, what time did it start? What did it feel like? And start to really delve deeper into what's happened with this patient. They'll then also take blood tests if they think that's necessary. Most patients will have some kind of blood tests on the whole. An ECG if it wasn't urgent, so if perhaps they haven't come in with chest pain but they are over 70 and they just want to do that full assessment by getting their ECG done. We could give more analgesia at this point. They might feel nauseous, so we can get some anti-sickness. Any other investigations will be done here. So it might be urine dips or urine samples, pregnancy tests. They might have gone for x-ray and come back. And then we can also give other sort of more basic treatments. So if any really quick dressings need to be done, any medications or IVs that can be started. The doctors will also see the patients, not at the same time usually. It's usually the nurse gets there first and then the doctor. Again, they will see them in time order. They just there's about 1 million doctors that sort of are in the department, and they just pick up and see the next patients once they've done. So it's a bit potluck which doctor you'll get, but they're all fantastic. From here, patients are usually either discharged home, so they might have treatment with some medications to take or some advice, or they will be admitted, and that's usually to AMU, the acute medical unit, or the surgical assessment unit, but they might also go directly to a specialty ward. They might go straight to a respiratory ward, or the CLI if it's a gynecological problem. And again, we're always aware of that lovely 4-hour target. So RATS, which stands for Rapid Assessment and Treatment. So it's supposed to be really quick. Again, another sort of 10-15 minute quick assessment, quick initial treatment to stop any problems developing and make sure people are seen in the best order. So this now is in the old trolley bay, which is sort of, if you go into A&E, it's the main area of the department where the coordinator will stand, and there's lots of cubicles in a sort of a square with lots of nursing desks in the middle. So this area is where all the ambulances come through. So every single ambulance that arrives at the hospital, they will wheel their patients off the back of the ambulance into a cubicle in RATS. At the moment, we've got 15 cubicles and 3 quiet rooms for patients to be seen in. And again, they must be ideally offloaded, so onto a hospital bed, triaged by a nurse, and the assessment started, all within 15 minutes. That's to make sure that we don't miss any patients that are particularly poorly or perhaps need to go and be seen in resus. And also that means that the ambulances and the crew are released to go back out and go and help more people, basically. So again, the nurse's role here, so as soon as that patient will arrive on the hospital trolley, nurse will go in, perhaps with a healthcare assistant. First thing they'll do is a set of observations, get them undressed. We do like to get most patients, even at least their top half, put them into a hospital gown. That just makes it easier to do things like bloods, x-rays, ECGs, and if they do deteriorate, we've got that quicker access to get their chest exposed. So the nurse will also start that assessment process. It is called the nursing assessment, where they'll be asking why they've come in, getting that background history of what's happened, past medical history, any allergies, and sort of delving really deep into what's going on with this patient. Triage them on the system, so assigning them that number category of severity. They might decide that blood tests are needed, which again, quite a lot of patients will have a blood test. ECG for both urgent chest pain and if that patient is over, probably about over 70. They can then quickly start any initial treatments, so might be analgesia, as we said before. If it's query sepsis, they might be able to get a doctor to come and help them, get some IVs going. And then all of that has to be documented. And the idea is that the patients move out of RATS once all these things are done. So within sort of 15-20 minutes, ideally. That nurse will then have to hand over that patient to the next area and also transfer them across. There are doctors in RATS, or there's usually one doctor, and they will sort of really be sort of floating about and they won't necessarily have to get involved with each and every patient. It's more up to the nurse to ask for doctor's input. So they might have, ask them to prescribe something like some Oromorph for pain. Might need them to have a quick look about what x-rays to order. If it's a possible stroke, could you, come and do a quick assessment and we can get a CT head scan ordered. Just those really, really urgent investigations to either make our patients stable or comfortable or safe, basically. And again, as soon as that bottom hits the bed in the hospital, that 4-hour clock has begun. So Majors or Trolley Bay, and again this has now moved, so this was in the main department where rats is now. Trolley Bay is now where the old CDU, OPED and children's area used to be, so sort of tucked around the back, almost like you've gone into a ward area. So these patients often they've come from rats if they need to stay on a bed, or they may be able to walk and sort of sit in the chairs in that area, so they might have been a walk-in patient, stayed in Majors, and this is where they go after triage for their treatments and to be seen by the doctors. There's now 4 bays of varying sizes. I think a few have 6 beds and a couple have 4 beds. And then there's also 3 individual side rooms, so that's we can get about 25 patients on trolleys in there. So this is people who need to be on a trolley. They can't just be sat out in a chair, and they will need some not one-to-one monitoring, but quite close monitoring and a fair bit of input. So all the nursing assessments and triage should be done before they get to this point, ideally. So the nursing role in this area is to give those further treatments and do those extra investigations. These are more led by what the doctors would like. So they might want different sets of bloods that haven't been done already. They might suggest, this is where they might suggest some IV antibiotics, any injections, so tetanus injections, any like cardiac medications. They might be attached to cardiac monitors and have further ECGs here. We might do more urine dips and pregnancy tests. The nurse is also responsible here for referrals to some areas, so they might be chasing beds if the patient is going to be admitted into the hospital, or they will help with the discharge process if the patient's lucky enough to go home. So this would be, making sure the patient is safe, might organise transport, TTO medications, any advice for that patient to go home with. So we've got lots and lots of leaflets on all different conditions. So if you come in with a head injury, what sorts of things to look out for. If you need to go home with any other equipment like crutches, how to manoeuvre themselves with those. Obviously the nurses and the healthcare assistants also here help with the ADL, so their activities of daily living, so going to the toilet. They might need to get dressed. If we've undressed everybody, they might need help getting redressed into their own clothes or something suitable to go home in. Sometimes we have to shower patients that come in not the best state, unfortunately. And all of this, as with everything nursing, must be documented. So that's quite a big part of the job. And then if the patients are here for a couple of hours, which it has been known to be in Trolley Bay when the hospital's full for well over 12 hours. So I've gone home, I've left my patients at the end of a shift, gone home, come back the next day, and those patients are still there, which is quite unfortunate, but they are made comfortable on a proper bed. We can get teas and coffees and lots of sandwiches and biscuits. No hot meals, unfortunately, but we can do what we can. And they usually only stay there for that period of time if the hospital is really, really full. So through that whole process, obviously, patients will need to be consistently sort of observed, reassessed with their observations. That does tend to be more of a healthcare assistant job. We often do hourly obs, but if they're there for a while, we can step that down as the patient needs. So, as I said, the patients arrive in this Trolley Bay or Majors area from rats. They might come from resus, who are not so poorly anymore, but they still need to be on a bed and be seen by the doctors. or they might have walked in and actually been too poorly to sit out in a chair. And as I said, patients will either go to the wards from here, which again is like the AMU, EAUS, or directly to speciality like OPM, older persons, or they might be discharged home from here, which is the hope. And again, we've got that lovely 4-hour target to keep an eye on, which is more of the floor coordinator's job. If you were the nurse or the student nurse in this area, it's not, you need to be aware, definitely, because you might be able to chase doctors in ward areas to make sure the patient doesn't breach. But that is more of a role that the coordinating nurses will keep an eye on throughout the shift. So then we have a look at resus, which is one of the most sought after places, I would think, in A&E. So I think we all know what happens in here really. So there's 5 cubicles, which are primarily for adult patients, and we've got 1 child cubicle, but if it's full, adults can obviously go in there as well. So resus is for our patients who need sort of that really immediate care or really close continuous observation. They arrive directly out of the ambulance, so they bypass triage and rats, and they come straight in the back door into resus. Or the same as if they've come in the helicopter, they come through the back door straight into resus. Or we might have those that have walked in the front door. For example, a colleague of mine who was the streaming nurse one day, mum walked in with a small baby in her arms. Triage nurse noticed that the baby was quite blue and floppy, so the triage nurse picked up the baby and just basically ran round to resus, sort of sounded the alarm and got that baby seen to straight away. I myself have been streaming at the front door, and I've had somebody I think he fell off a ladder, and he'd really badly cut his head, and it looked like basically someone had poured a bucket of red paint over him. So we wheeled him straight round because we couldn't assess properly how much blood he had lost, and we really needed to get that sorted so that he didn't become more unwell. There might also be patients that have been in the other areas of the department and have deteriorated while they've been there for lots of different reasons. So usually the ambulance crew or the helicopter crew, they know the sorts of patients that would be appropriate to go into resus. And if they think they have someone that's quite poorly and would be suitable, they do something called a pre-alert. And this is where probably in casualty and things like that, you might see the big red phone ringing. We've got a red phone, but it's actually black. And this should only be answered by somebody, usually a nurse or doctor, who's had the assessment training. And they basically take a really brief handover from that paramedic crew, give them a bit more direction about, yes, I think that patient should be seen in resus, please go straight there. Or they might say, oh no, that doesn't sound too bad, I think we might be able to deal with that in majors, so please just go into rats as normal. The nurse or whoever took that phone call would then let the coordinator know if they hadn't taken it themselves, and also let the team in resus know, because they might need to make room if it's full, or ideally it's just that they can get prepared for that patient to come in. So if it's a cardiac arrest, for example, they can get the space ready, get all the equipment that they might need, the adrenaline, the defib all ready, so as soon as that patient arrives, they can start treatment straight away. So in resus, if you're the nurse or student nurse working in there, you basically do a little bit of everything. So because you've bypassed that streaming triage nurse, so you have to do all of the things in resus. So you're going to assess, which is usually at the same time as the doctors. So you can do quite a bit of it through just listening to their conversations, but you can also ask your own questions to the patients if you're able to. You triage them on the computer system, which usually put them at the more severe cases because they're already in resus. You then start investigations, which will certainly be some blood tests, might be cultures as well, ECGs. Those are sort of the two main initial investigations that we do. Treatments, it's quite easy to get treatments started in resus because you've got quite a lot of doctors in there, and they're firing out what treatments, what medications they want, and the nurses often do help with organising things like x-rays to come in, or perhaps they might call one of the speciality like the orthopaedic doctors. They might put out something called a trauma call that the doctors have asked for. The nurses are sort of responsible for doing things like initiating the major hemorrhage protocol. So if someone's had a really major bleed or a trauma, we need to get some blood products pretty quickly, so nurses can order those from the lab. It might be a healthcare assistant or a student or a nurse that pops down to the lab to get that blood. Nurses in resus also do transfers outside of the hospital. So I myself have gone over to Addenbrooke's with a patient in the back of an ambulance. So this isn't very common, but it's for those patients that need more care or different care than the paramedic crew can give. So the patient I went with, for example, had an arterial line in, and the paramedics and the technicians aren't trained how to manage an arterial line. So I had to go with them in that respect, which is really fascinating, really interesting, a little bit scary. So you do need to have extra training to do that, but I think it is certainly worthwhile. And the nurses also will then transfer all patients, so they escort them if they go anywhere else in the hospital, which is likely to be a ward or ITU, HDU. The nurses will go with them, hand over to the next nursing team, make sure the documentation is done. Sometimes we do have patients that go home from resus, probably more often than you would think, which is fantastic. That's the ideal case. And again, we've got that 4-hour target that applies even to the patients in resus. So it is a busy job in there, but it can be really, really exciting. Keeps you busy, certainly does keep you busy. And I would recommend, anybody getting some experience in there. So we've got these GP pods, which there's a diagram of them here. That's actually what they look like. Out the front of A&E, which are new for this year, I do believe. So this is to try and, they've sort of installed to try and limit the amount of patients that were being seen through the main department that perhaps were more inappropriate for A&E. There are more things that you should see your GP about, but we all know that it's quite hard often to get a GP appointment, so people do tend to come to A&E instead. So these pods were put out the front, just behind the streaming nurse. So this is for walk-in patients. So that streaming nurse right at the front will ask the patient, what's brought them in today, and they might say, I've had a flare-up of my back pain, for example. So really that's something that you need to be seen by a GP for. So then they'll redirect them just to the left of them, and there is a GP sat just there, or a receptionist, and they do their own little triage and decide whether they're happy to see them or not. So this is quite a clever system really, because if they get seen by this GP, they don't come under that 4-hour clock because they're not actually entering A&E. The GPs are not employed by A&E, they are like community GPs, so they sort of fall under a different category. And they do give out time appointments, so if it gets quite busy, there might be a queue of patients, but I've never actually seen that long of a queue there at the moment, which is quite good. There's 2 pods, and I think they do run 2 of them most of the time, but sometimes it may just be 1. And as I said, they're not A&E staff, and all of the all of the appointments do get fed back and recorded, and that information goes back to your actual GP, so that it's that continuation of care. And these can be really good, they still do everything that a GP would do. They have all your records up there, so it is literally just like, a bit like going to a walk-in centre. So then we've got minors, or used to be called minors, and minor injuries and illnesses. So this is an area where patients have got something minor, I suppose. Might be an injury, it might be an illness. So injuries, quite a lot of possible broken bones go to minors, which sounds a bit surprising. But it might be things like broken fingers, broken toes, it's mostly broken sort of lower leg from the knee down, where they're in a wheelchair, they're in a fair bit of pain, but it's a fairly small fracture. They might have had sporting accidents, they've got cuts and grazes or sprains and things like that. They're all sort of minor injuries. We get quite a lot of people who've been doing some DIY and accidentally tried to cut off a digit. And then you get the minor illnesses, which is, more things a bit like injuries or infections to the eyes and ears. We've got quite a lot of cat bites that come through because they can be quite nasty infections. Might be things like UTIs, or a bit of whiplash from a car crash perhaps that happened a week ago. It may be a chronic condition that's flared up again that the GP is not quite happy to see, or the GP pods aren't running. They will get seen here instead. Usually all these patients do get discharged home, but sometimes they do have to actually be admitted after a bit of more of an assessment. So it might be, again, like those cat bites. The patients might have to be admitted to have IV antibiotics. If the bones that are broken are actually more severe than initially thought, again, they might have to be admitted for any surgeries. So streaming nurse will send these patients round to minors, which is sort of just outside of the main department. They will then be seen the same way, so triage nurse will see them in time order, and again do that further assessment. So what's brought you in, what's happened, a bit of a timeline perhaps, more detail, past medical history. They'll do the set of observations if they think it's needed for these minor injuries. We don't always have to. Booking x-rays is quite a big one round in minors. Analgesia again is a really big one. A lot of paracetamol is given out here. And then they'll see, they go back out into the waiting room, and then they get called in again to be either seen by a GP, an ACP, so advanced clinical practitioner, or an EMP, which is like emergency nurse practitioner. Basically those professionals who can see and treat and diagnose patients. There'll be another nurse, like a band 5 nurse, or it might be a band 4 assistant practitioner that will help those doctors, etc., with some of the treatments. They might do things like help with dressings or stitches perhaps if they've been trained. We give out quite a few crutches. We might do some injections, some medications, TTOs if they're going home, and they basically that nurse will really coordinate the area because it is sort of stretched out a little bit. And minors usually only runs between 8 o'clock in the morning and 2 o'clock in the morning, so most of the day. But those few hours early morning, it does close, just because not as many people come in with all these things that we've talked about. So during those hours, anybody that's come in that is suitable for minors would instead get seen in the majors department, so ambulatory majors. Okay, and I'm not sure if I mentioned it, but we've got the 4-hour target as well, starts and applies over here too. So then we've got the Children's Emergency Department, which is shortened to CHED quite often. So CHED sees all patients that are 15 years and under. So anyone who is 16 and over actually gets seen in the adult areas. But if you're 15 and under, no matter which way you've come in, if you've walked in, come in by ambulance, come in by helicopter, you will go round to CHED, and that's majors and minor injuries. So all the minor injuries get seen. So all those playground injuries or rugby and football injuries, they get sent round to CHED. They've got quite a big playroom, which is a bit like a waiting room with lots of toys and usually a bit of a movie playing. And then they've got 7 cubicles at the moment and a quiet room if they need to use it. There should usually be a paediatric trained nurse round in CHED, but there isn't always. So in A&E, a lot of the adult trained nurses will do 2 or 3 days to train to look after children in A&E, which again can seem quite daunting to begin with, especially if you've never really had much to do with looking after children. But once you get into it, it's actually very much the same as the adult areas. There's just a few small differences. But what is the same is again your process. So the streaming nurse will send all the children round to CHED. They'll go in the waiting room, and the triage nurse round in CHED will see them again in time order. Bring them into a little side room with the parents usually. It's usually the parents that do a fair bit of the talking and the explaining. But if the child is able to and happy to, some of them really want to tell their story, then they absolutely can. So that triage nurse will put them on the system in their severity category and do the set of observations if they need, start doing that assessment, so what's happened. They could again order the x-rays and give out any analgesia like Calpol and things, and they might ask if they think they need a wee sample, just let the parents know so they don't accidentally take the little one off to have a wee and then we realise that we need a sample. Patients and parents will then go sit back in the waiting room unless that triage nurse thinks they need to be seen immediately because they're quite poorly. And then there'll be another nurse that's sort of the treatment nurse, I suppose, and they'll go and see and call the patients into the cubicle, often with the doctors or the ACPs, and do a bit more of the treatments and further investigations. We do some ECGs. It's very rare that you would do blood tests for children unless they really warrant it, because it's not very pleasant and it's quite challenging sometimes. If they're broken bones, then the nurses and some of the healthcare assistants help with plastering and things like that, which is basically the same role through the rest of the department, but for little people instead. If the patients are transferred, they would usually go to either CAU, which is the Children's Emergency Assessment Unit, or they'll go to Buxton. the children's ward for need to be admitted for a bit longer. So the nurse will have to transfer them because it is quite a complete opposite end of the hospital. So they do need to be escorted by a nurse, or they might have to send them around to resus if they deteriorate or they think they're quite poorly. And we've got again a mixture of doctors, ACPs and EMPs that see all of the children as well. They sort of rotate. And yet again, we've got that lovely 4-hour target. So OPED, which I did mention right at the beginning, it stands for Older Persons Emergency Department, which is not operational at the moment due to COVID, but usually 6 cubicles, which is for patients who are over 80 and meet a certain criteria. So that is that they're not surgical patients, so no fractures or anything like that. Their NNUH 2 score is less than 3, and that they need to be in a bed basically, so they're not ambulatory. Patients, they come directly off of the ambulance usually, because if they're walk-in patients, it does tend to be that they're fit to sit. Minors patients who will meet this criteria, except the non-ambulatory, will be seen in minors. Most patients go back home, discharged back home or to residential homes, or they'll be admitted to the OPM ward, which is right next door. This unit was really lovely because the doctors that worked there were all OPM doctors and consultants, and actually they knew their patients quite well, and they were really keen at getting them home as quickly as possible rather than admitting them. I won't go into it again, but that nursing role is exactly the same. We've got the triage, we've got assessments and treatments, etc., etc. Hopefully that will be up and running again, but I haven't heard about when that might be at the moment. So this is a little bit of a slide to sort of demonstrate those pathways through the department, because I do appreciate I've just told you lots of different areas, and each individual patient might go backwards and forwards and sideways, but basically you've got your patient arrives. Can they go to GP? Yes, then they get seen by the GP. If no, then that streaming nurse will then choose which area to send them to. So if it's resus, they go straight to resus and bypass all of this middle bit. If it's majors, then they go into the main area. Minors get seen in minors if it's within those times, and then they sort of stay in that path. The majors will then basically come down and be either ambulatory, or they might have to go and get seen in resus. And then basically right at the bottom, they're either admitted or they're discharged. If you want to take oh no, try and rub it out. If you want to take a quick picture of that to study in your own time, I'll start touching it so you can just take a quick snapshot, or you can, obviously rewind the video once it's finished. But it just gives you a little bit of a snapshot about all the different areas. So that is the different areas. Finally, we got through all of those. If you've got any questions about those different areas, you can either pop a comment below, or you can send me an email. My address will be right at the end of this. So looking really, really briefly at the nursing role in A&E, which I have talked about a fair bit already. I've got a little bit of a summary here. So the initial assessment and the triage, finding out what's going on with the patients. They do sort of come up with plans of care and suggestions, quite often give quite a few suggestions to the doctors. They start the investigations, ECGs, bloods, urines, etc. All those ADLs and that holistic treatment of a patient. So that might just be talking to them, being there for them. They might just be quite lonely and they need someone to talk to. They might not have eaten for a little while. They might need washing, toileting. We still do all of that care that we would think was perhaps more traditionally done on a ward. Nurses do make referrals, often it is more the doctors, but we do quite a few fast tracks for different things, like ectopic pregnancies, for example. Escalate any care or problems is quite a major role, so that will be escalating it to the doctor medical team, or it might be to senior nurses, but basically to make sure that our patients are seen in the best order and given the best care. We transfer our patients and we hand over to other nurses. Discharge, as I've said, and that's all aspects of discharge, similar to that on the ward. So you've got your transport, packing them up ready, TTOs, cannulas out, family informed, really, really similar sorts of discharge process. And we'll also really are advocates for our patients and their relatives. We are often the voice for them, which is again the same on the wards. That is a nursing role in a nutshell. There's obviously lots and lots more to it, but I would run out of room to explain it all. So a lot of students that I've spoken to get a little bit nervous before they go for placement, particularly in A&E, because they think, well, what am I going to do in A&E? So I had a think and thought, well, what is a student nurse responsible for in A&E? And actually this is the list that I came up with. And if you might notice, it is exactly the same as the nursing role. The only difference is that everything that you guys would do as a student nurse needs to be done under supervision. And you've got the luxury of being able to shadow lots of people to learn the different areas. You can do spokes and see more of the patient pathways, and you basically, one of your main jobs is to ask as many questions as you can come up with. But there isn't anything in A&E that you shouldn't be doing as a student nurse unless you're not safe to do it. We don't want you taking bloods or doing cannulas and things like that, but the rest of the process really you can get as involved in as possible. Just need to make sure that you're working within your own competency as we do with anything with nursing. Okay, so now we are going to have a look at, I think I've got 5 different presentations that I thought were sort of really quite common and also a little bit interesting as well. So first one we're going to look at is overdose. So I thought people usually want to know a little bit more about, and because you hear quite a few myths and old stories about how it's treated on the TV and casualty and things like that. So overdose is also referred to as poisoning, and that's due to sort of the adverse effects it has on the entire body. You are poisoning your body if you have an overdose. It's a pretty complex area to talk about, as every single patient that comes in with an overdose is different. So unfortunately we don't have time to discuss all of the aspects, so I'm just going to really focus on paracetamol and opioid overdose, and the sort of initial assessments that come along with those presentations. So overdose can be broken into intentional or unintentional overdose, and it is really, really important to establish which one it is at that assessment and triage stage. Intentional is obviously they've done this on purpose, or unintentional, they haven't done this on purpose. So I had a patient that had a bit of a cold, quite a bad cold, had been taking day nurse as well as paracetamol, and she'd done it for a couple of days and hadn't realised that there was paracetamol in the day nurse. So it was quite reasonable, small overdose, and it was unintentional. She didn't do it to cause any damage to herself. Overdose patients come into A&E either they can come in as a walk-in patient through the front door. More often than not, they might come in through via ambulance and RATs, or they might even come in via the air ambulance helicopter. The location where they go into A&E will be based on the nurse assessment. So, if they are quite poorly, then they go to resus, or they don't often go to minors, so it will either really be majors or resus, or CHED if they're under 15. So I've put here some of the assessment questions to think about. So if you're that nurse, either at triage or the treatment nurse doing a bit of investigation, these are the sorts of things you're going to start thinking about. So the GCS level, the Glasgow Coma Scale, is really, really important. The paramedics will also do a lot of these observations, but you need to repeat them. So, if are they conscious? Are they able to talk to you? That gives you a really clear indication of how poorly they are initially, and you marry that up with their observations, blood pressure, their pulse, etc. Pretty much all observations could be affected, so it might be their pulse high or low, their blood pressure high or low, temperature might be affected, and you can't really gauge which, there's not a textbook example. It's just if they're abnormal is what we sort of look for. The behaviour of the patient, so are they really, really agitated, quite aggressive, or are they really reserved, a bit drawn in? Are they wanting to engage with you, or do they not want to talk to you at all? Are they sleepy? Do they look sweaty? It gives you a bit of an indication about the effects whatever they've taken is having on them, and their mental state as well. And if they want to be there, do they want help or do they not? Obviously, really, really important question is, what did they take? So what have they had an overdose on, and when did they take it? That when is really, really important, and I'll come back to that in a few minutes. But what they took, how much they took, so it might be that they can tell you exactly how many milligrams or grams that they took, or they might say, I took 2 packets. Whatever information you can get is better. If the patient is not really engaging very much, or their GCS is quite low, so they're actually not that conscious and can't have a conversation with you, the paramedics that brought them in, or the family that came with them, might be able to tell you what packets they found, which again is not a definite answer of what they took and how much. It's an indication, which is we need to go off of as more information as we can possibly get. Why did they take it? Again, that comes back to that sort of intentional, unintentional. Was it a mistake? Did they want to die? Or did they just actually, they might be in chronic pain or having really severe mental health problem, and actually they just wanted to have a rest and go to sleep, and that's the only way they thought they could. Some people do it because they do want to die, but by the time they arrive, they might have changed their mind, and that is obviously a completely valid thing to think. When they took it, so we need to know as close to the minute, really, I suppose, particularly for paracetamol, when they took it. It might be that they staggered it and they've been taking it slowly over a couple of days, a week, or it might be that they've took it all in one go. It might have been only an hour ago and they immediately regretted their decision, so called for help. It might have been 10 hours ago and somebody's found them not very well. I've already said sort of how much. Is there anyone else at risk? So this is, getting into your safeguarding. Is there any children at home? Did the children witness any of this? Where are the children? Are they safe? Was there anyone else? Was this just one person taking the overdose, or was it a small group? Is it a pair? Again, every situation is different, but we just need to eliminate that there's nobody else that's at risk. And if there is, that's when we sort of get safeguarding team and the police involved. We would usually do an ECG for most overdoses, just to rule out any problems with rhythm and rates and things like that, because I am focusing on paracetamol and opioids, but a lot of patients do take whatever medication that they can find, and they might be cardiac medications or something that's going to affect their heart. We do look at their past medical history. Have they done this before? Have they got mental health problems in the past? It might be more of their history might indicate how they've got hold of different medications. So I had a patient, for example, that took an overdose of his medications for his transplant. I think he had a kidney transplant. So that was quite a pertinent thing to ask. Have they got any pain? Is this, are the symptoms they're getting pain? And where is that pain? Is it chest pain? Stomach pain is quite a common one. Or a headache is another common one, the side effect from whatever they've had. And then we also do, eventually when they've come back, look at the blood test results, which usually take about an hour in A&E to come back. And going back to what they took, we need to identify, was it prescription medication? So like paracetamol, or it might even be a morphine or an Oromorph, cardiac medication, or was it an illicit drug? Was it cocaine, or any other illegal drugs? Basically, that doesn't mean that we're going to call the police unless we are worried. We just need to know exactly what they have taken, or it might even be that they've swallowed or ingested a household product like bleach or something. So these are the sort of observations and assessments that we do as a nurse when they come in the department. And our treatment and where that patient goes very, very much depends on that assessment and how the patient has presented, which every single one is very, very different. We might have to call security to help us with some patients. We might have to special others, particularly if they're really not wanting help. So we have to always be considering mental capacity and the patient's best interests. So if they're if they're refusing us to give them any kind of treatment or certain treatments, then the doctors are going to have to come in and do some mental capacity assessments, perhaps. If they've got low GCS and they're not fully conscious, we're going to have to make those treatment decisions in the best interest of that patient, as with in all areas of the hospital. So opioid overdose, so this is either could be an illicit drug, so like cocaine or heroin, for example, or it could be prescription drug like morphine, Oromorph, fentanyl. There's lots of variations for it. But the treatment for the opioid, which is in both of those, is something called naloxone, which you may have heard of. This basically reverses the effects of the opioid by blocking those receptors in the brain. The initial dose for adults is 400 micrograms, which will often be done pre-hospital by the paramedics. The They can also, I think, give one of these the next dose of the 800 if they think it's needed. But usually this is where they come into hospital. We might give them another couple of doses. If that still hasn't had enough of an effect, then it can be stepped up to 2 milligrams, and we can start a continuous infusion if we need to. What's quite interesting about naloxone is that it can work absolutely instantaneously. So your patient can be having a really low GCS and a rest rate of, only like 5 breaths per minute, for example. You can give them this injection, and then they'll sit bolt upright in their bed. It is that quick of a reaction, but it doesn't last very long. So we might get a few minutes of them, sitting up and talking, and if they've still got too much of the drug in their system, that again, those opioid receptors will kick back in, and they might get symptomatic again, and that's why we have to keep giving a dose until that patient's a bit more stable. Other treatments you might need to give as well, which, it depends on what symptoms they're having. So if they're also having cardiac symptoms, or they've got, renal damage, then we treat those differently. But to stop the effects of the opioid, which will be like the depression on the respiratory system particularly, we give that naloxone quite quickly, and that can be given either IM or IV. I think usually we start with IM and move on from there. So paracetamol, so about half of all drug overdoses in the UK are from paracetamol, and it's one of the leading causes for liver failure, unfortunately. The onset of the symptoms from paracetamol is relatively slow. It could be more than 24 or 48 hours, and that can delay the treatment, as people, they might have, on the Monday taken the overdose, feel fine and think, oh, well, that was, a silly thing to do, but I'm okay. And then it's not till a couple of days later when they think, oh, I'm not feeling very well, and then they might then seek help, but some damage might have already been done. And obviously the longer it's left untreated, then the more damage that can be done. So we have to take paracetamol levels, like a blood test, to gauge the level of toxicity in their system, which sort of depends on how much they've taken. But paracetamol plasma levels can't actually be detected if the bloods are taken less than 4 hours after it was ingested. So if they took the paracetamol and came in an hour later to A&E, we'd have to wait until that 4 hours to actually take the bloods, because it just wouldn't show up in the results. So that is why when I said about asking the timing and when they took the overdose is really, really important, particularly with paracetamol. Some patients, we do have to take their words on when they took it, or family might have a little bit more of a clue if their GCS is low. But if they can't speak, or they won't tell us, then we sort of have to do the test, and we might do it again in a few hours just to see the comparison. If the patient took the overdose less than an hour ago, so they took it at 3 o'clock, for example, and they came into A&E at 3:30, then we can give that activated charcoal, which some of you may have heard of before. So it's taken through the mouth orally, and it basically binds the toxins together in the stomach to stop it being absorbed through the system and causing damage to the liver and things. This isn't really very often done. I've actually never given it myself, because that's, an hour is such a short window to take the overdose and actually get yourself to A&E and through the triage system. So that's not quite often given, but it is a treatment option. The main treatment for paracetamol is something called N-acetylcysteine, which I always struggle to pronounce, often called NAC, which is, I think, comes into this bit, or the brand is actually called Parvlex that we use in our trust. This is, so the doctors will prescribe this. It's all done based on the patient's weight, so the nurse will be responsible for actually weighing the patient as best we can, and then the doctor will prescribe it. This is an example of the prescription chart. It used to be paper, but I think now it's moved on to EPMA, of how they prescribe the Parvlex. So you see down the side here, we've got the weight, so the doctor will circle roughly up to sort of round it up. So let's say they were 50 kilograms, they'd circle that, sign it at the bottom and give that to the nurse to draw up and give. It does look quite overwhelming, but once you get used to it, it's not too bad. So up here we've got the fluid. So dose 1, so I haven't had any yet, so dose 1 we're going to go, so we need 200 mils of 5% glucose, so it's usually in a small little bag, and then we need to make sure we've got the right drug, so that's the Parvlex, which is the brand name, and this column here will tell you the volume you need in mils, so you don't actually have to do that much maths calculations, you just have to follow the line across. So if our patient weighed 50 kilograms, then we need 38 mils of Parvlex going into 200 mils of glucose. And then that is going to run over 15 minutes, which usually goes through a pump. Once that bag has gone through, we then straight away move on to dose 2, which again, we follow the line across. So the volume we need is now 13 mils, and it's going to go in 500 mils of 5% glucose, which is just a bigger bag, and this time it's going to go over 4 hours. And then obviously you sign in your date down the bottom. Again, when that's finished, we move on to dose 3, which is a litre of 5% glucose, and we need 25 mils. They are quite easy to get used to once you've had a few goes, and again, I do recommend sort of exploring them a little bit. So yeah, that is the main treatment for paracetamol, and usually these patients will be admitted onto AMU at the moment to have that treatment, because I can't go back unfortunately, but that whole treatment plan can take over 20 hours to give, which is a long time, so they need to be admitted to be monitored for that and to have the treatment. Once it's finished, they will have a blood test done immediately for paracetamol levels to see if there's still any toxicity left in their system. If there is, unfortunately, that treatment will have to be done, like, repeated in full again, and then, they might then end up staying perhaps on HDU or being seen more on the liver specialist wards. Mental health team often do come and see them before they're discharged as well. This treatment does often work the first time, but depends on how much they have taken. So if you've got, that's all I'm going to talk about with paracetamol. As I said, it is quite complicated, so that's sort of more of a introduction to it, if you like. If you've got any questions about overdose in particular, again, just please pop a comment below, or send me an email, which again, my address will pop up at the end. So as you can see, what we've moved on to is abdominal pain or abdo pain. It's quite a common presentation. It's a daily occurrence. and again, it's quite a complex assessment process. So I'm going to go through what I think is sort of the main important things to think about. So again, we're going to look at the assessment questions and things to think about. When they come to A&E, they often go through the walk-in, so go through your streaming and your triage nurse, or they'll come in through ambulance and into RAPT or resus. There's lots and lots of questions to ask. First of all, probably is, where is the pain? So point it out to me. Don't just go for it's abdominal. We need to, point it out exactly where it is. And I'll come back to that a bit in a second, actually. How bad is the pain? And we use the 0 to 10 scale, usually in A&E. And just have a look at them. Are they guarding, like this man in the picture here? He's guarding his tummy, he's protecting it because it's painful. Are they bent over? Do they look like they're in abdominal pain? Has anything happened to trigger this pain? What were they doing at the time that it started? Were they exercising? Were they straining or lifting something heavy? Was it a trauma? So have they had an accident, a car accident? Have they fallen off of something? Do they think it's food related? Do they think they're pregnant? Lots of different things. So what was happening at the time that this pain started? And then get them to describe pain. What does it feel like to them? This is quite a hard question for a lot of people, and it is very subjective, but whatever they can describe it in does give us a better indication. It's usually things like, is it sharp? Is it throbbing? Is it does it come and go, or is it constant? Is it a really dull pain? Is it a crampy pain? Does it go right through them? Whatever words they really want to use to describe it is fine. You just document whatever they have said, but you might need to prompt them on things if they might be in so much pain they can't really think too straightly. Does anything that they do or take relieve the pain? So is it better when they are bent over forward? Is it better when they're lying, or they're lying on their side? Is it better if they're pacing up and down? Have they had any medication that's made it better? So have they had any pain relief or any like gastro medication? And if it is a medication, what helped and when did they last have some or any medication? So the paramedics might have given them something and that might have helped, and that's a really good indication. Have they got any other symptoms other than just pain in their tummy? This is a really, really important one to sort of think about what else is going on. So this would be things like, have they vomited? If they have, how many times? When was the last time? Have they got any bleeding that they've noticed? That might be from their back passage, it might be when they're weeing, they might be coughing up any blood. Have they got any shortness of breath? Is it taking their breath away? Have they been constipated? So you probably want to ask them when they last had their bowels open, and if that was normal for them. That's the key question. When did they last pass any urine? And again, was that normal for them, or was it painful, etc.? Have they noticed any blood in their stool? Do they think that they're pregnant? So have they done a pregnancy test that was positive? And you want to have a look at their tummy as well. So is it swollen? That could be one of the symptoms. It might feel hard to touch if they allow you to touch it. You might notice any redness or bruising. That's more of a sort of a trauma indication. Any symptoms that they can sort of relate to this tummy pain gives us a really good indication. We're going to want to find out about their past medical history. So have they got any cardiac history, alcohol consumption? Have they had any surgery, particularly recently? Have they been in retention in the past? Again, pregnancies, any recent diagnoses that they might have had for various things, might be ulcers or anything really. Then obviously we're going to do our observations as part of our assessment and triage process, and this again gives us a really good clue as to the severity and what's going on. So if you're thinking it might be cardiac, which we'll talk about in a second, you might want to, when you do their blood pressure, check it on both arms to see if there's any difference between the two arms. Pregnancy tests, I've said, we can repeat in A&E, but we also want to do a urine dip test, just a normal one, see what's happening in their urine. As I've said, look at your patient. What do they look like? Are they sweaty? Are they really short of breath? Guarding that tummy. They might be screaming, or they might be actually really quiet, and the pain that they say they're in doesn't really match what they look like. But we all handle pain very, very differently. So if we have to go on the level of pain that our patients say they're in, so if they say my pain is 10 out of 10 and they're sat there on their phone, we still document that that is 10 out of 10. So we have to go on what the patient feels. If you're comfortable as a nurse, you have a look at the tummy, and then if you're comfortable to just sort of gently palpate and touch the tummy, but only if you're happy to do so. And if the patient is happy, they might be in too much pain for you to do that, so it might be worth you just leaving that for the doctors to do, so they only have to go through it once. ECGs, again, if it's cardiac, doctors might request some x-rays and CT scans to see what's going on inside that abdomen. So when I said a few minutes ago about asking your patient to point out where the pain is, we want them to really identify it to an area. So I've popped these pictures up. This one on the left here gives you the names of the different quadrants of the stomach, and what's really important is to think about what is underneath that area of skin. So under here we've got the stomach and the spleen under here. We've got the bowel under this bit. We've got ovaries and fallopian tubes under here. Again, we've got the bowel here, liver up in this bit, and we've got the diaphragm and a bit of, this is going into the thoracic area up here. So wherever they're pointing to gives you more of an indication of what is causing the pain. Where's that pain coming from? Again, if it's on sort of this right iliac area, that might be more of an indication for appendicitis, because that's the common area. If it's here in the middle, it might be more urine retention, is what I'm trying to say. And this is just a really good tool to think, what's underneath where that pain is, what can be causing it. However, that is a lot of quadrants to remember. So when you're documenting it, or you're talking and handing over to the doctors, even if you just say upper right, upper left, or lower right and left quadrant, that is a good enough indication for them to then already know roughly where that pain is, or it might be bang in the middle. So if anything, just remember upper and lower left and upper and lower right. Okay, and then when you get, if you work there and you get a bit more confident, you can start using the quadrant names. So just going to have a quick, because abdominal pain, as I said, there's lots of stuff going on under there. So the causes for abdominal pain can be massive and varying. So I've just listed a few of the really common ones, just to give you a bit of an overview. So obviously we've got your appendicitis, which is your sort of blocked or inflamed appendix and your gallstones. Cholecystitis is the gallbladder inflammation. It might be pancreatitis, which often is caused by alcohol, or again, it might be gallstones. Bowel obstruction, so that can actually, it sounds perhaps a little bit silly, but it can be absolutely excruciatingly painful, and if that obstruction is too large, it can actually cause a necrosis of the bowels and actually mean that that patient has to end up having quite major surgery and perhaps a stoma. Triple AAA, is aortic aneurysm. This can either be dissected, so it can be sort of broken, or it could be fully ruptured and just, bleeding out basically. And this is a case that would need to be seen in resus. This is really, really urgent. And the pain for that, so when you ask your patients where is the pain and how to describe it, it's often radiates. It's in the middle of their chest or their stomach, and it radiates right through them to the back. And when you have a look at their tummy and their chest, you might also see like a pulsating mass. So, that aorta is basically pumping and it's ruptured. You might be able to see it. Peritonitis, which is usually following a problem with a different organ in the abdomen. So it's, usually an inflammation of the membrane and the lining of the cavity of the abdomen. And one of the signs, like the red flags for that would be a really rigid, hard stomach when you palpated it. GI bleed, gastric bleed, could be, again, hundreds of reasons for this. It might be an ulcer in the stomach, or Crohn's disease, cancers, lots of different things. And it's important to sort of assess if the bleeding is upper or lower GI. So is it coming out of the mouth, or is it coming out of the back passage? So if they're vomiting or passing blood, is it fresh? Is it bright red? Because that indicates recent bleed. Or if it's vomit, is it what we call, you probably heard, coffee ground? So it's like it's a dried blood really, and it's a quite grainy and bitty. And if they're passing it in their stool, is it black and tarry? That's the dry blood coming through the bowel, and that's also called melena. Either is bad, whether it's fresh blood or dry blood, neither are very good. It might be a hernia that's causing the abdominal pain, so that muscle sort of protruding through the stomach muscle wall, which again you might be able to see if you do a visual assessment. Retention, urinary retention, really, really painful. This might be a blocked catheter, or it might just be that they're in retention and they just can't pass any urine. Can be so painful, and for this we tend to use the bladder scanner we've got in the department. So you'd see probably a really distended, bloated, full lower tummy. I'd want to get the bladder scan on there to see how much. If it's a blocked catheter, then fairly simply, I suppose, we change the catheter. If there's no catheter but they can't pass anything, then we can insert a catheter and relieve that pain and that tension as quickly as we can, and then solve why did they go into retention. Constipation, so again, seems a bit silly, come to A&E because you're constipated, but again can be really, really painful, and that can often be actually diagnosed on an x-ray, but we want to be careful that that doesn't lead to a bowel obstruction. Diarrhea and vomiting, again, ideally you shouldn't be coming to A&E with these things, infective things, and they're best treated at home, but many do come in because it can be so painful and quite worrying, and they get put in an isolation bay as much as we can. Renal colic, like kidney stones, this can be really painful again. and so basically causing an obstruction from your kidneys. Pain is usually in the sides, obviously where your kidneys are, or they might be in the groin and radiating through to the back. And actually ibuprofen is quite a good pain relief for this one. Usually PR as well is best. And they might need surgery to remove the stones if they can't be, flushed out with lots of fluids and passed through. And we actually do have in our ED a fast track process for this because it is so painful. A trauma might cause some abdominal pain. So it might be a fall from a height, or they might have had a fight and been injured in the stomach, a car crash, they might have been lifting something and it's pulled. They might have been playing with their kids and their kids have, accidentally kicked them in the stomach, or they've been playing like rugby or a different sport. And this might have either just bruised them, or it might have actually ruptured something and caused some bleeding. This is all, harder to tell what's going on. And I had a young guy that came into resus once with abdominal pain. He looked really, really awful. It was really not obvious what was wrong with him. So he was a semi-professional footballer, had, through playing football, I think, got a couple of broken ribs, so wasn't training for a couple of weeks or so. Decided to start doing a little bit of exercise, so I think he just went for a run, and then he started to feel really, really unwell and came into A&E. And it was because I did my trauma day and I got told about, think about what is underneath the skin in these different areas of the stomach, that actually I helped the doctor diagnose that it was the broken rib had actually ruptured the sac around his spleen, which had caused a really slow bleed into that sac. So his blood pressure and his blood count were going down very slowly. So that was quite interesting. This might, all of these traumas might be really tender to touch, or you might see bruising, or you might see nothing at all. Another cause for abdo pain is ectopic pregnancies, so where the fertilized egg has sort of settled in the fallopian tube where it shouldn't be. Again, very painful and can cause a really serious rupture of the fallopian tube, might lead to removal of the fallopian tube and or the ovary. So needs to be seen, and again there's a fast track for this, I do believe, to get them up to Cry Ward. If you think it might be this, we need to do a pregnancy test when they come in. And also one of the other red flags for this, for some reason, I don't really know the science behind it, is that the women also tend to get a shoulder tip pain on the opposite side. It's like a deferred pain. Again, I don't know the science behind it, but that is quite a common symptom. Women might also get lots of other different pregnancy-related pains that they come to A&E, almost in a panic, or they might actually be unfortunately having a miscarriage. So you can ask them about the bleeding. Or we do get a few women that come in who are having a lot of pain after having an abortion. And that again needs really good investigating. And then again, as with most things, we need to always be aware about sepsis. So lots of these things can cause sepsis, and it's just something to always have as a nurse in the back of your mind. So abdo pain is, can be caused by anything. So that's why it's really important to really ask lots of questions, do as much investigating as you can to sort of give you more of an indication of what's going on. And these patients do, individually, it depends what's wrong. They'll be admitted to medical team, surgical team, they might go straight up to theatre, or they might be discharged home. So that's all on abdo pain. Again, any questions, pop in the comments or ping me an email. and I'll get back to you. So the next presentation is head injuries. Lots and lots of reasons again for head injury, and lots of varying severity, the individual basis. So people will still attend through rats and walking, through the front door, and roughly 1.4 million people come in with head injury to A&Es across the country every year. Head injuries based around trauma, so it doesn't include superficial facial injuries, so like lacerations and things. Lots and lots of reasons for head injury, and these are sort of the most common ones. So falls, and that is all ages. It could be children or adults. A lot of elderly who have falls, unfortunately, from either standing or from a height, and bang their head. And they can be coming in from care homes, or they could be at home. Lots of adults who they might have fallen off their bike, off of swings, might have been drunk and fallen off of a wall or a wheelie bin or something. They might have fallen off a horse. Like, anything you can fall off of, somebody's fallen off of it at some point. RTC, which is a road traffic collision, a car crash. It could be any sort of crash, from a simple little bump, or it might be a full-on roll and really severe crash. Sports injuries, a lot of rugby injuries or hockey. Again, it might be falling in any of the sports, or they might be accidentally kicked in the head or hit in the head with like a hockey puck or something. List is endless for that as well. Might have had a fight and been punched or fallen in the fight, or they might have been hit with something like a blunt trauma, like a bottle or anything really. They might be drunk or they might not be, so there might be alcohol involved. What have I put on there? Seizures. So seizures, somebody might have, they might be epileptic or they might not be. And if they've been standing and gone into seizure, might have hit their head, or they may have, been sitting down, but through having the seizure, they might have accidentally, hit their head on some furniture or something. But with all of these, it's just really, really important to not forget to check the neck. So when we talk about head injury, that encompasses the neck as well, which I will talk about a little bit more in a moment. So looking at our assessment questions and things to consider as nurses. So what happened? We call this the mechanism of injury. It's a really good phrase to remember. So this includes how high they were, how did they do it? Did they fall? Was it a fight? How high did they fall? What did they land on? Was it sand or was it concrete? Was it bricks? Was it gravel? Did they have a helmet on? What speed were they going? All those different questions. What happened immediately after as well? So did they lose consciousness straight away? Did they vomit? Were they winded? Were they confused? Did they get sort of a blurry vision? Did they get up and walk away straight away? What was their immediate reaction? GCS assessment, the Glasgow Coma Scale assessment, must be done with their OBS on arrival, and just think about their baseline. So if they are elderly from a care home, then they might have dementia or something, so their GCS might normally be a little bit lower than somebody without dementia, so that needs to be taken into consideration. Or they might have a learning disability and the same applies, or they might be a child. If they're drunk, then we still do the GCS based on what we actually see, not what you think. So you don't make any considerations that they've had alcohol. We need to do it on what we see and what our patients say to us, because yes, they may, you know, have alcohol in their system, but the way they're behaving might be more to do with the head injury than the alcohol, particularly as the alcohol, you know, quite quickly wears off. So never be influenced by the alcohol behaviour. Have they got any wounds from this fall? Lacerations to sort of the head, the back of the head and the top of the head rather than the face? Any fractures that you think might be there? Bruising? If you get a cut on your head, it does tend to bleed an awful lot, just because the amount of pressure and blood through the capillaries in your head. So they often do need either stitching or gluing. Gluing usually is done by the nurses, and stitching is usually by the doctors. And we do aim to sort of wash any dry blood out of patients' hair as much as we possibly can, so doctors can get a really good assessment, and we're trying to limit that infection risk. And if there are any fractures which would be confirmed on an X-ray or CT, then patients usually have to have a tetanus shot as well, which is an IM injection. We've got something called panda eyes. There's my picture. So bruising around both eyes, which is called panda eyes in England, and this is a really big red flag indication of a basal skull fracture. So an injury right at the base of your head, where you sort of it joins to your neck, and that can, you know, lead to some really severe complications if it's not treated. So if you see that, then there's somebody, perhaps if you're the triage nurse, you might want to get them round into resus, or grab a doctor to get them a really urgent CT head. We're going to ask obviously our patients about the pain. Have they got any pain in their head or anywhere else? Have they got a headache, or is it, you know, what type of pain is it? And what would they score it from 0 to 10? And again, don't forget to consider any safeguarding issues and the neck pain. Have they got pain in their neck? So if they've fallen in a care home, might need a little bit of investigation as to why. If they're drunk, was there anyone else involved, any children? All of these safety features. So neck assessment, which we mustn't forget. So neck injuries can either be the soft tissue, so like the muscle and ligaments and things, or the bony injury, so you know actually your vertebrae and your spinal cord, or it could be a mixture of both. And it might be that patients don't realise straight away that their neck is painful if there's a bit of concussion or shock, but obviously, you know, we know how important the neck is, and the spinal cord with controlling the rest of our body, so we need to really protect that neck. Ambulance crews do a really great assessment of necks, and those that are high risk mechanisms, so you know, car crashes or falls from horses and things, will have their C-spine checked by paramedics. So you feel down the vertebrae and ask if they've got any pain. If they have, then usually they will have that C-spine immobilized, usually a combination of a hard collar around the neck, red, usually soft blocks on either side, like near your ears, to secure your head down, and you'd have something called a scoop, a hard board underneath you. I have got this picture and it is not very good, I apologise, it's the best picture I could find. So we've got this is the hard collar that goes under the chin to support the head and keep it still, and then these blocks here on either side which will strap down the top of their head, and then this lady would be lying on a board at the same time. They'll then come into the hospital like this, and doctors will usually be the ones to then have to assess if they've got a spinal injury, and then they can confirm it on an X-ray or a CT, and patients can't be removed from this until a doctor has said that it's safe to do so. And walk-in patients, again, the nurses, as you're doing your assessment, will ask if patient's got any neck pain, and you would just gently feel down the vertebrae and ask if they've got any pain. If they do, on the actual bones, then that's an indication that they need to be collared. This is called collar and block. They need this, and they need to be laid down as well. If you palpate the sides of their necks and they've got pain, that's more of an indication of like the soft tissue and the muscles, and they don't necessarily have to be collared and blocked. And that's more things like whiplash, which again is still painful, but we don't need to worry so much about protecting the neck for that. So I think that is my discussion a bit about head injuries. Again, that is an absolute whistle-stop tour, and patients will either be again admitted, particularly if it's a severe head injury and their consciousness level has been altered, or they need overnight observations perhaps. But a lot of patients will also go home the same day, which is really fortunate. They just need to go home with an adult that's going to be with them overnight. In some cases, and we give them some advice cards on things to look out for concussion. So again, any comments about head injuries, just pop them below or ping me an email. And then I thought head injury moves us quite nicely onto car crashes, which is what we sort of see a lot in Casualty and all those TV programs. As with everything I've said, severity can range from not even needing to attend A&E from a crash to being a polytrauma call, and having multiple injuries in multiple systems and areas of the body, and everything that goes in between. Symptoms also vary from, no pain, no injuries, nothing, to having to take a few days to actually develop and come out, particularly things like whiplash, or it might be like that young chap I explained that his injury might be quite slow bleed, but that still then might end up being life-threatening. Oh, sorry, there we go. So, as with everything, we need a really thorough assessment as a nurse at the triage and assessment. And some of the things we're going to think about is, again, that mechanism of injury. Were they hit from the front, from the side, from the back? How did the car move? Did it roll? Did it hit another car? So was it front and back? What was the mechanism? What happened? The speed of both the vehicles, or as best an estimate as we can get, is really, really important. So if it's a head-on collision, both cars were going at 60 miles an hour, the impact speed is actually 120 miles an hour, and that is quite a significant amount of speed. If it's one car was stationary and got hit from behind and that moving car was going at 20, then the impact speed is only 20. So we need to know both vehicles if it was two vehicles, or if they hit a lamppost or just lost control and veered off the edge. Where they're wearing a seatbelt. So this isn't to make judgment, it's just so that we know what sort of injuries they might get, how that mechanism, how the body moved in this accident, and where the airbag's deployed is, a safety feature to think about. It's good that they were deployed, but that might also cause some different injuries. If they're on a motorbike or bicycle, where they're wearing a helmet, some paramedics might bring in the helmet so we can sort of assess the amount of damage that was done, what the helmet absorbed, and what level of injury the brain might have endured. Have they got any wounds or injuries that are open, any fractures, any pain? Again, neck pain is really important, head, or it might be anywhere else on their body. GCSE, so this is going back to your head injury. because that is a really major risk of a car crash. The damage to the car or the bike, whatever they were on, if the patient can't tell you, then paramedics might be able to tell you if they were at the scene, or even the police if they've come in as well. And if the police do come, they only tend to come if it was quite a severe crash. So the fact that they're there might indicate, you know, the amount of speed that was going on or the damage that was done to the cars. Ask them again, same with head injury, what happened straight away? Did you lose consciousness? Have you vomited? Do you feel nauseous? Did you get up and walk straight away? Were you confused? All of those things, again, coming back to the head injury questions. Coming into A&E, full traumas, which is based more on what's happened and the speed and the mechanism of injury. So those full traumas will go into resus. Whiplash, which might be straight away or it might be a couple of days old, might be able to be seen by the GPs in the pods, and sort of those other things in between, which will be more like possible neck injury or head injury, will get seen in majors where they have to lay down. I've popped some pictures on here just to show you some signs of injuries. So this one was a seat belt. So, you know, very painful. Again, it might take a couple of days to actually come up, but you might, if they've got shoulder pain or neck pain, you might want to have a look, you know, have they broken any collarbones? Have they got abdominal pain for where the seatbelt was around their tummy? This is a crash dummy, but a picture, because you might hear the phrase that they bullseyed the window, and that's what this means basically, that their head hit the window, which is obviously not very good, and they left this bullseye mark in the window. And this is quite a good picture to show the bit of the mechanism of injury and what happens to the spine. So this is a normal spine here. Impact, so if the impact was they were hit from behind, that indicates how the neck was moved, so then if they might get pain around this area. If the impact was from the front, their head might go back, so they might hit their head on something, and you can see in this little zoomed in picture the potential damage to the spine and the spinal column. And again, if they've hyperflexed forwards, that injury that might occur in the spine. So that's why we always need to think neck. They might have done this bullseye at the same time, so this might be what we think about first, but we mustn't forget to check the neck. Okay. So that again is a summary of road traffic collisions. I wouldn't suggest that you start palpating necks if you're going to A&E unless you're being, you know, if you're a student, you're being really supervised and talked through it, because you don't want to cause any more injuries. And if you qualify and you work there, then you'll go on an actual spinal day, a spinal assessment day. So you'll learn how to do it safely and how to do lots of log rolls with the patients to protect that neck. So just leave some comments if you've got any questions, or email me if you've got anything else that you come up with afterwards. And then we're going to move swiftly on to lower limb injuries. So I wanted to get a little bit of sort of minor injuries in there as well to give you a flavour of more of the department. So lower limb injuries can range from the toes to the knees, basically. And I wanted to just really briefly talk about them. So looking at the toes first, so these are the patients that are going to probably be walk-in patients, I would hope, not an ambulance. Come in, streaming nurse would then send them straight round to minors, and the triage nurse and assessment nurse would see them, and these are the sorts of questions we're going to look at. So mechanism of injury, yet again, how did it happen? What happened? Was your toe crushed? Did you stub it? Did you trip on something? How was it injured? When did it happen? Was it today? Is it brand new, or is it actually a couple of days old? Pain levels 0 to 10, and obviously you can give some analgesia if they've got pain. Then you need to also really get a good look at this foot. So we do something called look, feel and move with these assessments. So we need to look at the foot. Can you see any deformity, or hopefully not, but any bones protruding out? It looks really, really not normal. You might have to compare it to the other foot that's not damaged, because we've all got different shapes and size feet. Have they got any lacerations or cuts or any other wounds like bruising? Is there any swelling that you can see? And then try and get them to walk on it. So can they put weight through it and walk on it, and if so, how much or how little? One of the big questions is, which toe is it? That's probably one of your first questions if it's not blindingly obvious. And have a look at the nail bed as well. Is there any bleeding under the nail bed? And you might want to just feel the bones to try and see if there's any bony pain, or is it more of a soft tissue? So some of the treatments, really briefly, for toe injuries. If it's not your big toe, so if it's any of these little piggies, and there's no deformity or bones protruding out, no wounds, then actually there's nothing that will be done for those toes. It's best that you just go home, rest it, put some ice on it, and elevate it. So even if it is broken, there isn't really anything that we can do about it, unfortunately. If it is your big toe, your hallux, which this one here, then we might be able to buddy splint it a bit like this one, this picture here, to try, or if it's the second toe, they could be buddied in between here, because that's quite, your big toes are really important for balance. If it's been crushed, your big toe here, then it might need surgery. If there's a crushing and you've got this, a bit like this picture here, this blood collection underneath the toenail, that's going to build up quite a lot of pressure and it might cause some necrosis. So usually just a fine bore needle is just popped into the nail bed to relieve that pressure and drain that blood out. Another treatment would be if if it is a wound, if it's been crushed or the toenail might have already fallen off, then we just put a simple, or quite complicated toe dressing on there. So yeah, this is a picture of someone who's perhaps broken their little toe, and again, really bad bruising, but there isn't much we can do about it. The best thing to do is called RICE, which I've already mentioned. So rest the injury or the injured area, ice it for 20 minutes a couple of times a day, compress it to make sure any swelling goes down, and elevate it above heart level. And that is really the best treatment for these that you can do at home, save your trip to A&E. And then moving up to sort of the foot and the ankle. Same assessment principles apply. Mechanism of injury. Was it crushed? Did they jump and land on it funny? Were they walking and they tripped sideways? They jumped from a great height? You're going to want to look at the 2 feet again to compare. Have they got any deformities, things poking out when they shouldn't be, swelling, bruising, range of movement that they've got, because we're going to again do our look, feel and move. A clear deformity like a fractured dislocation, which I've got a nice picture in a second, will actually need to be seen in resus, because if your ankle is is broken and twisted out to the side, you could lose the blood supply to that foot and you might end up losing the foot. So that needs to be sent right round to resus, and they'll have quite intense analgesia for that to be pulled and realigned and then plastered, or they might need surgery. So we need to, if they can, if it's not physically that deformed, again, can they weight bear on it? If so, how much or how little? And how much movement have they got lifting, bending their ankle and their foot, wiggling their toes. We use something called the Ottawa Ankle and Foot Rules, which I'll show you in a second, and this is a nursing assessment tool to decide whether we think that they need an x-ray and if they've got a fracture or not. So for those less serious, even if you do think it might be broken, they're usually seen in majors, and they can have an x-ray, and maybe they might need a boot, or they might need to be plastered around in minors. So, and if you do palpate it and you've got no bony pain, that again indicates it's a ligament damage rather than a fracture. So this is the Ottawa ankle rule picture. So this is basically done by palpating or feeling the foot and the ankle in specific areas to identify any bony pain. So to assess the foot first, you're going to feel the inside of the malleolus, which is the ankle bone, on both sides. So get my highlighter out, which is this area here, and sort of up about 6 centimeters up their ankle. And you're going to feel the bone, and if they've got any pain when you press, again, that's a bony pain, so that would indicate possible fracture. You're also going to feel along the bottom of the 5th metatarsal, which is the little toe. So along here, if they've got any bony pain there. And then you're going to feel the navicular bone, which is sort of the middle foot here, this top of the ankle area, which actually I think the next picture, this is a little bit clearer. So the black areas, so this is where you're going to feel ankles, underneath the little toe, and the top of the foot. So any pain when you press any of these areas and the inability to put any weight through that foot then requires an x-ray. Doesn't mean to say that when the doctors assess them they think, oh actually I'm just going to do an x-ray to be sure, but it just limits the risks of nurses sort of exposing patients to radiation more than necessary. So if we're looking at possible like an ankle injury, it's the same process of feeling the bony pain. You're going to feel the ankle bones, so again over here, and if they can't weight bear at all, then that indicates that there's quite a high chance that there's a fracture. And just something to be aware of, if someone's jumped off of something and landed flat on both feet, they've got pain, just feel these parts of the ankle bone. They do tend to break bilaterally from high jumps. Something to think about during your assessments. So this is quite a typical picture of what you might see of someone who's come in with a sprained or possible fractured ankle. So this is where you're gonna have looked at your feet. You've got both feet out and you've looked at how they can walk. You're going to ask them to move their foot up and down, side to side. Can they wiggle their toes? So get that movement, and then you're going to start to palpate. So you're going to feel up the ankle bones on each side. It might be quite painful on this foot. You're going to feel underneath the 5th metatarsal, and you're going to feel at the top of the ankle here. I would quite imagine that there might be a fracture in this ankle somewhere, just from the amount of bruising and swelling. Might be quite hard to feel the bones because of the swelling, and it might be particularly painful for them. You might also want to just feel this toe here just to make sure that there's no fractures. Don't know what was actually wrong with this person's foot, but I thought it was quite a good picture to show you. If there's no fractures, then again that rest, ice, compression and elevation would be really, really good for this particular foot. So that's your lower limb injuries. I'm not going to talk about knees and knee assessments because actually they're a lot more complex, and I don't personally know enough about them. It's more the doctors and the ACPs that do the knee assessments. But again, please do ask any questions you might have in the comments, or email me. Oh, I forgot about this lovely picture. So this is a fractured dislocation. So that's the x-ray of it and the foot. So as you can see, it's really, really deformed. It shouldn't be pointing that way. So it's both fractured, which you can tell in the x-ray, and it's dislocated. So that really needs to be pulled back straight and set in plaster as soon as possible so that they don't lose any circulation to that foot. And again, that'll be a resus patient. So that is sort of your introduction to A&E and different presentations and treatment options. I hope it's given you a bit of an insight into NNUH, the areas and the different pathways that patients take, as well as a bit of a flavour for the nursing role. I've covered a few presentations just to introduce them, but as I've highlighted, every person is different, and it can be a lot more in detail than what I've covered. Please do ask any questions, and this is my email on the screen now, or you can leave some comments, and any feedback would be really appreciated so that I can fine-tune this for the future. I hope you found that it's been useful, and that perhaps it's given you a bit more confidence to have a few shifts or a placement perhaps in A&E, and maybe even go and join the team there. So thank you very much for your time and your attention, for joining us, and I hope to speak to you all soon. Thank you.